I think the answer is in the design. And I'll share with you my thoughts regarding this. The design is different of this implant because it has a plateau. And what about and it has a taper lock joint. This is the plateau here. It's not a screw. It's like parallel sides where when it's a press fit implant, when you place it in the osteotomy, blood clot will fill between the different plateaus, and this blood will turn into bone later on. It has a taper lock joint, a friction fit joint there, and it has a convergent neck. And we'll talk about each one of those aspects of the design and how it reflects itself on the short implant success rate. As for the plateau, we have more surface area and better bone quality and better distribution of stresses. How come? The surface area, a study done by Dr. Mufto at Northeastern University comparing different implant systems of same size, diameter and length, and it showed that with the Bicon implant, we have about 2 to 8.5 millimeters of contact of size of the implant in comparison with others, which were 128, 196, 187, and 161. So the plateau design increased the surface area of the implant by 30 to 35% when compared to the screw type implant of the same size. Why? Because the thread depth of a V screw type implant is 0.24 to 0.37 millimeters, while the depth of each fin in a plateau type implant is 0.5 to 0.75 millimeters, so almost twice. So increasing the area will decrease the stresses, right, if we go back to the formula that we spoke about. What about better bone quality? And this is the main message I want to convey to you. In a study done by Mitchell and co-workers in '94, they said the bone anatomy for the plateau design is uniquely different compared to screw or rod bullet design root form dental implants. And this saying was also approved by P.I. Brenmark in his textbook, Osseointegration Book from Calvarium to Calcaneus, 2005. What did he say? He is explaining to us the healing process in a fractured long bone, in a fracture of a long bone, and the reduction. If points A are the points where we have bone-to-bone contact, and points B are the places where we have spaces which are filled with blood, like the plateau type implant. Regeneration of bone, however, always proceeds only in the hollow segments, in zone B, in the vicinity of blood vessels which have spread from the endosteal cavity where primary lamellar bone is formed. So here, we're having primary lamellar bone, not appositional bone or bone remodeling like that. And this is mentioned by P.I. Brenmark. What did Jack Lemon say at the University of Alabama at Birmingham? Plateau design root form implants have unique distribution and orientation of mineralized phases associated with the vasculature that was specific to the plateau design. This was specific to the plateau design. Haversian bone surrounds the plateau implant, whereas other implant designs have only a positional bone. So we're having a different bone inside this plateau. Let's go back to P.I. Brenmark and his textbook. And here he's trying to explain to us what's happening in the healing there when we have a screw-type implant in contact with bone in some sites, and in other sites we have space, and he exaggerated the space there. What does he say? Provided there is no implant micromotion, gaps at the interface appear to heal by intramembranous ossification, and regions of direct bone implant contact will heal by bone remodeling. So here we're having a positional bone remodeling, while there we're having direct lamellar bone or intramembranous bone. We're having different type of healing, different type of bone. And Jack Lemons comes with this histology of this implant that was explanted after 10 years of function. The hydroxyapatite to bone interface shows retained HA and local continuous HA to bone contact representing osseous integration 120 month in vivo. Look at the HA. It stays. Why? Because this is a press fit implant. When you put it in the osteotomy, those spaces are not in contact with bone. So the HA remains intact as it was when it was manufactured. The bone along the plateau indicates a mature biomechanically loaded structure that has developed a somewhat unique arrangement. General analysis from this two-dimensional midline section region shows that it's cantilever-like structure that would provide combination of strength, maintenance through dynamic force, transfer, and flexibility. So we're talking about different bone here. That's for the plateau. What about the distribution of forces in bone? Let's go for finite element analysis. And also the study done by Mitchell and Lemons in '94, they said the distribution of mature bone was greatest along the apical portion of the bicon implant. So the mature bone was mainly at the apical portion of the implant, not at the crestal like the others. Also, Dr. Muftu at the Northeastern University, and showing us with the vertical forces here, whether it's a long implant or a short implant, whether in type 2 or in type 4 bone or type 3 bone, the forces are mainly concentrated at the apical part of this implant. So we're having an implant that transforms the forces to the apical part. So all the body of this implant is resisting masticatory forces. What about the lateral forces? Also with the lateral forces, we're having in type 4 bone or 3 or 2, we're having the forces to the apical part. So Dr. Muftu published that the bicon implant shows an even stress distribution throughout the implant bone interface. Maximum stress is found at the bottom of the bicon implants, whereas maximum stress is found at the tip of the Astra ITI and Nobel Biocare implant. Interesting. That's for the plateau, giving us more surface area, giving us better bone, and giving us distribution of forces to the apical part of the implant. What about the taper lock joint and what's its significance? Taper lock joint is a friction fit joint. There, no micromotion and no pumping of bacteria. So no vertical bone loss. Not like with the screw type implant, and that was described with vertical bone loss less than 1.5 millimeter the first year and less than 2 millimeters every year after. That would be a successful implant according to Smith and Zarr. And Piatelli came to explain to us in 2003 that the location of the micro gap existing between the implant neck and the abutment represents the most common factor in inducing bone loss. So it was not like in the beginning we thought it was a physiologic bone loss as P.I. Brandmark told us. It is a pathologic bone loss due to pumping of bacteria at the joint. While with the bicon implant we have a proven bacterially sealed implant to abutment connection with a micro gap less than 0.5 microns. And why 0.5 microns here? Because the smallest microorganism in the mouth is the AA, and it is larger than 0.5 microns. So nothing can penetrate. That was published in the iDromy in 2005. So the locking taper giving us no micromotion and no bacterial pumping, so we have a stable bone height. What's the relevance? If we have a 6 millimeter implant that we place today, after 10 years it would be 6 millimeters implant in bone. If we have a slip fit joint connection, other implant type that loses 2 millimeters the first year and 0.2 millimeters every year, after 10 years we're having 2 millimeters of bone and we lost 4. If not, we lost all the implant. So we've gone back to the study done at BU by Dibar and his colleagues. It was a 5-year study on the bone loss of the bicon implant. The mean change in radiographic bone levels were minus 0.08 millimeter for the non-6 times 5.7 millimeter implant and minus 0.03 millimeter for the 6 times 5.7 millimeter implant. And that was published in 2008. And let me show you one of my clinical cases. In 1997, those are the implants were placed, and look at them after 11 years, 2008. Here we had 2 millimeters of bone, and there we had 3 millimeters of bone. 11 years, still we have 2 millimeters of bone and 3 millimeters of bone. So we're having a stable bone level. And finally, let's talk about the convergent neck and what does it mean in our study here. It is the platform switched in design since 1985. The design was that, like this convergent neck, since 1985. So it's horizontal biologic width, soft tissue implant relation, preventing bacterial penetration and protecting bone. We have a horizontal biologic width, not only vertical biologic width. Let's take a look and compare a screw-type implant with vertical biologic width and the plateau-type implant with horizontal biologic width. We have bone protected there with a direct bone. Here we have soft tissue to the titanium relation. It's not like with the other switching platform concepts where you have metal and metal on both sides. Here it's bone and metal. Okay. Histological sections revealed that gingival tissue around the taper-locking connected implants were consistent with healthy gingival tissues. Coelho et al. In 2005. Convergent neck will give us wider bone coverage on top of the implant. Compare the three modules. This module of the convergent neck of the Bicon implant and the other modules, and that was published in Dental Implant 2004 by Coelho. We have much more bone to protect this implant here around the head of the implant than there. And if you want to place this implant in this bone, you have to cut the bone to put it down. You have to lose this bone. While if you have thinner bone and you're placing that, then you graft the sides, you might have a 0.5 millimeter bone around, and then it will fill later on. So you're having more bone to protect that implant than there. So some clinical cases to conclude my presentation. An old female that needed a single maxillary molar. She doesn't want to go to sinus grafts, so a single molar, 6 times 5.7 millimeter implant. Single mandibular molar, 5 times 6 millimeter implant. A molar, look at the sinus, proximity to the sinus, and a 6 times 5.7 millimeter implant. This was one of the cases that were included in immediate loading research, and that was a 6 times 5.7 millimeter implant. A 5 times 5 and 5 times 6 millimeter implant. Also a case with immediate loading with a 5 times 6 millimeter implant. But look at this case where this patient doesn't want to extract any of her teeth, but this one which has a periapical rarefaction. So we could go for sinus grafts here and there, subnasal floor elevation in this side, guided bone regeneration of this side because we had height. But what saved this case are those two short implants, because this is more predictable than the vertical bone augmentation procedures. So what saved me in this full mouth case were those two short implants, and this is a 5 years post-op restoration and X-ray. Also an old female that needed short implants everywhere, 8 millimeter implants everywhere, but here it was a 5 by 6 millimeter implant. Second molar occlusion. Okay, this gentleman is 20 years of age. He had orthodontic treatment, and the orthodontist gave us a minimal space between the canine and the molar. So we had to place this short implant, because of the sinus, very close to the molar. But because of the convergent neck, we still have bone and we still have interdental papilla. And between the two implants, which are very close to each other, because of the convergent neck, we still have bone and we could have interdental papilla. Almost kissing implant and tooth, but because of the convergent neck, we have 3 millimeters of bone, so we could have interdental papilla. Look at the cases when we placed the ceramic crowns, anteriorly and posteriorly, and look at it 3 years in function. Look at the bone levels, look at how proximal to the tooth, and 3 years in function clinically. Look at the natural look. This is the white and pink aesthetics we look for in implant dentistry. But because of the convergent neck, we could have this interdental papilla here and there. And I will conclude my presentation with this 8 years post-op restoration. There you can see a 5.7 millimeter implant, no sinus graft, an 8 millimeter implant, no sinus graft, 11 millimeter implant, we have plenty of bone. Look at the soft tissue after 8 years, and look how kissing implants, but still we have 3 millimeters of bone, still we have interdental papilla after 8 years. But look at the natural teeth which were crowned at the same time. We have some recession of gum tissue. So those are aesthetically better looking, although they were done together. I would like to thank you very much for your attention.